Assalamu alaikum. I am Dr. Farhana Islam, Associate Professor, Akij Medical College, Khulna. We are going to present now diabetes in pregnancy. In our country or in worldwide, diabetes is the most critical disease which may associate it over 5 to 12% of pregnancy, and which complicate the pregnancy, and also for the fetal complication associated with diabetes. What is diabetes? It is a metabolic disorder which causes insulin deficiency, either relative or absolute deficiency of the insulin in the body, so that ultimate goal is hyperglycemia. That means glucose level is increased in blood. It is absolute deficiency of the diabetes is insulin dependent diabetes, which is caused by beta cell abnormality, which may be due to autoimmune disorder and causes beta cell destruction. And another was relative deficiency. That means type 2 diabetes mellitus. It is usually occur due to peripheral insulin resistance. That means insulin is unable to work in the cell, so that glucose cannot enter into the cell, and ultimately the blood glucose level is increased. That is absolute deficiency of the insulin. That is due to insulin resistance. And another type is gestational diabetes mellitus. Now, concerned with gestational diabetes mellitus. What is gestational diabetes mellitus? It is the insulin resistance that occur only during pregnancy and only onset after 20 weeks of pregnancy. More specific is that. And the women who do not diabetic or in past or before pregnancy, sudden onset of diabetes during pregnancy. It is called gestational diabetes mellitus. Who are the risk factors for this gestational diabetes mellitus? We can categorize some people, some pregnant women in first antenatal visit, that they are maybe prone to diabetes in this pregnancy. The risk factor for gestational diabetes mellitus are: she has past history of diabetes in previous pregnancy, if her age is more than 30 years, if she has a family history of diabetes, like her grandfather or her father, mother, any parents or any sibling has a history of diabetes mellitus, or she has a history of recurrent pregnancy loss, or she has a history of stillbirth in previous pregnancy, or any history of delivery of the macrosomic baby in previous pregnancy. Macrosomic means overweight baby, more than 4 kg in case of our country. And if there is any infection in this pregnancy, like any urinary tract infection or chronic vulvovaginitis or any other infection in case of this pregnancy, those are high risk people for diabetes mellitus in this pregnancy or gestational, or risk factor for gestational diabetes mellitus. And if she has obese, and if she has a history of her birth weight was overweight in that country, according to, she has a also high risk for diabetes mellitus in pregnancy. Now, what are the screening tests? In this case, in those mother who has a high risk for diabetes mellitus in pregnancy, what are the screening process? There are several screening process, like random blood sugar or any glycosuria, urine for glucose test, and more specific now, glucose challenge test and oral glucose tolerance test. If a patient came to you anytime and she take meal and then she has no choice for other antenatal checkup, now we can done her glucose challenge test, which should be done by taking 50 gram glucose irrespective of taking any meal, and after 1 hour we should take her blood sugar, and this is called glucose challenge test. It is a exceed more than 130 milligram percent, then we can consider it as a gestational diabetes mellitus. And in case of glycosuria, if before 20 weeks of pregnancy there is several times glycosuria found. Glycosuria means glucose in urine. Usually glucose not found in urine, but in pregnancy normally there is tubular reabsorption is impaired or low and GFR is high, so that if there is blood sugar is normal but there is a glycosuria in repeated occasion before 20 weeks, then there is a chance of gestational diabetes mellitus. It is also a screening test for gestational diabetes mellitus. If there is no chance of another investigation and no facility for another investigation. And other is random blood sugar. It is usually non-specific, and in case of high risk case, usually we offer the oral glucose tolerance test for the patient, because it is more specific test for screening of gestational diabetes mellitus. We know that there is a nomenclature, impaired glucose tolerance test, like IGT. IGT means her blood glucose fasting level is normal, but 2 hours after glucose intake, 75 gram glucose intake, there is a blood sugar raise. We know that blood sugar raise means more than 140 milligram percent, and then if there is it is called IGT. And in case of pregnancy, this IGT is converted to gestational diabetes mellitus. That means her fasting blood sugar is below normal, and but her 2 hours after 75 gram glucose is more than 140 or 130 to 140. That means, and then there is 3 types of interpretation of oral glucose tolerance test. Fasting, and previously we told that 1 hour after, then 2 hours after, but more specific is fasting and 2 hours after 75 gram glucose. And there is 3 interpretation, like normal, gestational diabetes mellitus, and frank diabetes. Frank diabetes means there is some blood glucose level which is not within gestational diabetes mellitus level. It is a frank diabetes. That means this diabetes may be undiagnosed before pregnancy and overt diabetes now. So the level is normal fasting more than less than 100, and impaired glucose, that means gestational diabetes mellitus, is 100 to 125 or 126 milligram percent, and frank diabetes fasting is more than 126, and 2 hours after glucose, 75 gram glucose, normal, in case of normal, less than 140, and in case of impaired glucose, that means gestational diabetes mellitus, it should be more than 140 but less than 200, and in case of overt diabetes, that means frank diabetes mellitus, that should be more than 200. That means 11 gram per deciliter and milligram per deciliter. 11, more than 11 means there is a frank diabetes, or maybe undiagnosed before that. And in that case, we should be advised to take insulin without any delay. Now, that is at the screening test for gestational diabetes and in high risk case. And what are the effect? Why we should know about the diabetes mellitus in pregnancy, or why we are more concerned of that? What are the effects during pregnancy in diabetes? During pregnancy, effect of diabetes on pregnancy. That means some maternal effect and some fetal and neonatal effect. Maternal, what are the maternal effect? Most common maternal effects are abortion. Abortion, that means recurrent spontaneous abortion. She has not diagnosed diabetes before that, but she has a history of recurrent pregnancy loss. Recurrent pregnancy loss means 3 or more pregnancy loss without any diagnosed cause. First of all, we think about the diabetes. Then, preterm labor. Preterm labor means it is occurred due to either infection, that means recurrent urinary tract infection or vulvovaginitis, or due to polyhydramnios. Polyhydramnios means if there is an amniotic fluid more than 25. Upper limit of normal amniotic fluid is up to 24. If more than that, then it is called polyhydramnios. It is a complication of pregnancy in diabetes mellitus, in gestational diabetes. So, if there is a polyhydramnios or recurrent infection, there is a chance of preterm labor. And other complications are infection, we already mentioned it, and it also complicated by preeclampsia and eclampsia. Preeclampsia is more common in gestational diabetes or diabetes mellitus. And then polyhydramnios. Why there is polyhydramnios? Why there is a more amount of amniotic fluid is there? We should know about that. There is another complication, fetal complication, is macrosomia. What is macrosomia? Birth weight, or according to the age of the fetus, her birth weight is more than 10th percentile. That is macrosomia. In case of, we know that there is a growth chart of fetus. If there is more than 10th percentile, above that, then there is a macrosomia. That means baby weight is more than the normal for that gestational age. Why there is a macrosomia? The cause is maternal hyperglycemia, which means glucose level more than the normal in the blood, which goes into the fetus. And with the response of this hyperglycemia, in case of fetus, islet cell is more stimulated and more insulin is secreted from that. So that more insulin in the fetus in the fetal body, so that this insulin has a somatic effect, the somatic growth of the fetus, and more adipose tissue is also stored in the body, and this two cause fetal macrosomia. This adipose tissue deposition and somatic growth causes fetal macrosomia, and this fetal macrosomia causes a hyperplacentosis. Macrosomia, hyperplacentosis. Placenta is also large. These two causes fetus macrosomic, so this fetus causes more polyuria, and polyuria means she micturated more than the normal, and this urine goes into the amniotic fluid, so that amniotic fluid level is increased. And there is an hyperplacentosis, so that there is a placental vascular bed also increase, and there is a secretion of the amniotic fluid from those surface is also increased. So there is a chance of polyhydramnios. Then maternal distress. These polyhydramnios and macrosomia causes maternal distress. We found that there is a fundal height is more than the period of amenorrhea. This due to macrosomia and polyhydramnios, and this stress causes rise of blood pressure and preeclampsia of the mother. And another, if there is a chronic diabetes or diabetes mellitus is already there and then pregnancy occur, then there is a chance of vasculopathy, or if there is an already vasculopathy is there, diabetic vasculopathy like retinopathy or peripheral neuropathy, this will be worse during pregnancy. And if there is an only diabetes mellitus, now there is a chance of worsening of the diabetes control and may lead retinopathy or peripheral vascular neuropathy. And there is an also chance of coronary vascular disease, coronary artery disease. And last of all, there is also a chance of ketoacidosis. Why there is a ketoacidosis? The diabetic mother, previously diabetes, there is during pregnancy, diabetes mellitus is not controlled, and there is a chance of ketone body formation, because uncontrolled diabetes, when there is a pregnancy, need for carbohydrate and other substances also increase, and poor antenatal checkup may lead to ketoacidosis. Diabetic patient came to you with undiagnosed diabetic ketoacidosis. And now, what is the effect of fetus? Effect of this also effect of fetal more common complication is macrosomia and some congenital anomaly of the fetus. If during organogenesis diabetes is not controlled during organogenesis, then there is a chance of structural abnormality, that means congenital anomaly of the fetus. The most common congenital anomaly in central nervous system, renal system, and cardiovascular system, and other is gastrointestinal tract, and others are umbilical artery, single umbilical artery. More common central nervous system and skeletal system abnormalities are neural defect, opere spina bifida, or any microcephaly, caudal regression syndrome, and other sacral agenesis. And we usually found that more common and congenital anomaly in our country, like it's not common, but in diabetic complication we found several times anencephaly. Anencephaly more common in case of gestational diabetic complication than other. And other like extremity polydactyly, syndactyly, and in cardiovascular disease like VSD, ASD, quadration of aorta, phalangosteatology, those type of congenital anomalies may come in diabetic mellitus. And in case of renal agenesis or hydronephrosis or double ureter or polycystic kidneys, those are more common in diabetic complication renal system. And deattractive duodenal atresia or anorectal atresia, omphalocele, gastrocrisis, those are the common complications in gestational diabetes mellitus. All these occur in case of organogenesis, when if there is an diabetes not controlled hyperglycemia, so that the effect is that those congenital anomaly of the or structural anomaly of the baby. And other is macrosomia. We already mentioned the cause of macrosomia, and those are the complication of the. And in case of neonatal complication or in case of delivery, there is a more chance of fetal asphyxia and stillbirth injury, like maternal injury and fetal injury, because there is a macrosomic baby when passes through the pelvis, there is a chance of injury to the fetus and also maternal soft tissue injury occur. and there is a chance of intrauterine death also may occur in last 2 weeks of pregnancy. And other complication of the neonate, that is all fetal complication, and other complication of neonate after delivery, these macrosomic baby are more chance to hypoglycemic attack. Why? Because they are already in hyperglycemic state during pregnancy, and just after delivery, when there is a glucose level rapidly fall because there is no supply of glucose, so there is a chance of hypoglycemia after. It is more common complication after birth, and there is a birth asphyxia feature. There is this hypoxia, and if hypoglycemia is persistent, there is a convulsion coma, maybe neonatal death occur. And other complication is hyperbilirubinemia. There is macrosomic baby, so there is a chance of more RBC breakdown and more bilirubin release, and hyperbilirubinemia, that means neonatal jaundice. Chance of neonatal jaundice is more than the normal. And common complication of the diabetes in pregnancy. What are the complication of pregnancy on diabetes? If patient is diabetes before that of pregnancy, during pregnancy there is a worsening of diabetes control because of some cortisol or some steroid hormone increase in body during pregnancy, and some placental lactogen hormone. Those all are anti-insulin like action, and so that insulin function is also decreased during pregnancy due to this anti-insulin hormone in the body, so that there is a chance of worsening of the diabetes control, and there is a chance of retinopathy, neuropathy, and diabetes control is also poor. So that this diabetic patient should be more cautiously checking, and need of insulin also start if needed. There is a more risk of maternal and fetal in case of diabetes. Now we should end of this class. After that we should counseling about the management, and our investigation of diabetes in pregnancy should be later on. Thank you for patience hearing.